Assalamu alaikum. Hello. Likely to discuss about the second part of the psychiatry. Now I'd like to talk about the SSRI and SNRI associated sexual dysfunction. SSRI and SNRI may cause decreased libido, anorgasmia, and delayed ejaculation, and common cause of non-adherence. It is the common cause of non-adherence. So, SSRI and SNRI related sexual dysfunction, decreased libido, anorgasmia, delayed ejaculation, and common cause of non-adherence. In this type of patient, first of all, rule out the sexual dysfunction due to depression or other medical condition or primary sexual disorder. If there is any stress or relationship issue, if there is any use of substance, switch to non-SSRI and or non-SNRI antidepressant like bupropion or metazapine. Adjunctive therapy with sildenafil or bupropion, dose reduction for patient on high dose SSRI. Monitor for loss of efficacy. We know that SSRI and SNRI can cause sexual dysfunction, so switch to non-SSRI or non-SNRI like group of drug like bupropion and mirtazapine. Next topic is reactive attachment disorder. Like a 5-year-old boy is brought to emergency department complaints of with complaints of he's very sort of violent. He, the patient was placed with the aunt 4 months ago. Patient was placed with the aunt 4 months ago due to physical abuse and neglect by his parents. His teacher is concerned that he does not follow direction, rarely participates during group activities, and does not respond to praise. This is the important thing. He does not care actually. He actually neglects his parents, or and his aunts also says that he seems to get upset for no reason at times and usually starts throwing and breaking things. The patient is sitting on the floor playing with various toys. Physical examination shows no abnormalities. He makes eye contact and answer questions briefly before turning away to play by himself. Affect is indifferent with constricted range. What is your diagnosis? Your diagnosis is reactive attachment disorder. Reactive attachment disorder. In reactive attachment disorder, there is insufficient care, neglect, abuse, and inconsistent caregiving. Does not seek or respond to comfort. Unexplained irritability, fear, sadness, even after during safe encounters. Poor social responsiveness and limited positive effect. Some evidence less than 5 years associated feature toileting and sleeping difficulties, anxiety, aggression, and hyperactivity. What are the differential of these reactive attachment? It may be adjustment disorder, it may be post-traumatic disorder, there may be global developmental delay, there may be global or intellectual disability, it may be autism spectrum disorder, maybe depressive disorder. So these are its differentials of this reactive attachment disorder. Again, adjustment disorder, there may be global developmental delay, intellectual disability, autism spectrum disorder, anxiety, and depression. Early intervention and prompting, safe and stable and enriching environment, consisting responsive caregiving, psychological services like parenting skills, individual family counseling. And this is all about the reactive attachment disorder. It is inhibited social engagement disorder, DSAD. This inhibited social engagement disorder is another possible outcome of severe neglect or abuse. But unlike reactive attachment disorder, where children are emotionally distant, uh, but children with disinhibited social engagement disorder display over familiarity. That means even with adults, they do not know. They become over family over familiar and lack of appropriate boundary setting. Social anxiety disorder. Social anxiety disorder, also known as social phobia, like a 20-year-old a girl, he has problem. What type of problem? Important. He is he has some sort of problem. He is always anxious. He's always anxious. Uh, he recently ended with relationship with his boyfriend and has some sort of problem is going on, but the most important problem he is having, she is worried because she has an important presentation coming up in next few weeks. He has some family issues, but important thing, he has some important presentation coming up in the next few weeks, and is afraid that everyone will see how anxious I am. I am unable to perform that preparation. These things are biting him. These things are biting him. So this is a social phobia or social uh, anxiety disorder. And in social anxiety disorder, there is a on marked anxiety more than one social situation for 6 months. Marked anxiety more than one social anxiety for more than 6 months. Fear of scrutiny by others, humiliation or embarrassment. Social situation avoided and endured with intense distress. And marked impairment, social, academic, and occupational, and subtype specifier, and performance only. He has some sort of performance problem. In performance only subtype, beta blocker is the drug of choice. But uh, if it is not only performance, if it is as a whole social anxiety disorder, then SSRI is a drug of choice. Cognitive behavioral therapy should be think like a 31-year-old man. Now I would like to discuss about OCD. OCD, obsession compulsion. Obsession means recurrent, intrusive, anxiety provoking thoughts, urge, or images. Recurrent, intrusive, anxiety provoking thoughts, urge, or images. Like a 31-year-old woman uh, comes to the office for a 6-week postpartum visit. He's telling that he's telling that lots of things get passed on the baby to the breast milk. I don't want him to get exposed to something bad or hurt him in some way. She wears sterile gloves. It should not be. Look, these things. The woman, the mother, is wearing a gloves for breastfeeding her child. This is irrational. She washes fruits and vegetables, even his uh, mobile phone, for 3 to 4 times. This should not be done. She does not drink alcohol, so she is suffering from obsessive compulsive disorder. This is the important side you have to look, that she wear gloves, sterile gloves, when preparing formula, and showers every time before breastfeeding. This is unreal. This should not happen. So it is not postpartum psychosis. As the lady is a postpartum, so you have to rule out the postpartum psychosis. That's why I have already said that, why I have said postpartum psychosis. This is the case of obsessive compulsive disorder. There is obsession, there is compulsion. There is obsession means recurrent intrusive anxiety provoking thoughts, urges, or images, and compulsion response to obsession with repeated behavior or mental acts, behavior not connected realistically with preventing feared event, time consuming one time consuming more than 1 hour per day, causing significant distress. SSRI is a drug of choice. Cognitive behavior therapy expose and response prevention therapy should be given. It is difficult to differentiate delusion seen in postpartum psychosis from the obsession seen in OCD. However, these type of patients psychotic symptoms like hallucination, disorganized speech behavior that would have been seen in postpartum psychosis. In this patient, there is no hallucination, no disorganized speech or behavior problem as seen in the postpartum psychosis. He has some sort of compulsion, like he has to wear gloves, he has to make shower before breastfeeding. This is the thing is going on. Eh, in in obsessive compulsive disorder, SSRI is the first line symptom. SSRI is the first line symptom, and serotonin is the primary pharmacological target for OCD. In in autism spectrum disorder, there is a social deficit with onset early in the development. Social deficit with onset early in the development, difficulty sharing emotions, interest, and lack of verbal communication or eye contact, difficulty in developing or understanding relationship. Like an 18-month-old girl, he has some problem is he only say a one word only, no or yes, but he is not unable to say papa, mama, dada, bye bye. Uh, he is able to walk and starting to run, but the on examination the patient does not make eye contact and follow the doctor's gaze uh, when points out the object to her. Hearing is normal. So think about autism. Social deficit, restricted repetitive behavior, social deficits, difficulty in sharing emotion or interest, lack of non-verbal communication, like eye contact, difficulty in developing and understanding relationship, and restrictive repetitive behavior like hand flapping or speech uh, insistent or sameness routine, intense fixed interest, and adverse response to sensory input, language, comprehensive clinical evaluation, genetic testing, chromosomal microarray, fragile legs, and brain MRI, macrocephaly. Macrocephaly should be done, brain MRI, genetic testing should be done. Management is behavioral, speech and occupational therapy. Now I would like to discuss about alcohol withdrawal syndrome. This is a very important topic. Usually this type of things happen, alcohol withdrawal, this type of thing happens after major surgery. If patient is admitted for major surgery like laparoscopic partial colectomy, and after 2 days he is having confusion, agitation, there is 102-degree fever and hypertension, diaphoresis, and hallucination is found. So think about delirium tremens. So this type of patient admitted in the hospital, uh, who ha who has some sort of alcohol history should give benzodiazepine as an anxiolytic. Benzodiazepine as an anxiolytic, like you can give lorazepam or diazepam. Uh, if you don't give those anxiolytic, there may be alcohol withdrawal syndrome. Like a 15-year-old girl brought to the office. He has some sort of behavioral change. He has some sort of, the patient has increasingly anxious. The patient has increasingly anxious and started hearing man's voice and whispering at the nightmare. This is the thing you have. If you find this type of thing, you may think that this is psychotic feature. He has some sort of uh, whispering, whispering to his nightmare, maybe auditory hallucination. The patient increasingly withdrawn, and her parents, she frequently asked to sleep in their room due to bad dreams. Due to bad dreams, she asked her parents to live with her. She always been mature for her age and very popular at her school. But now she is clingy, prefer to stay home. She even wants do not want to go schooling. Do patient is oriented. She makes minimal contact and constricted reflex. These things happen for past 6 weeks. She's very anxious and started to hearing some sort of man's whispering. So in that particular case, you have to rule out the history of trauma exposure. PTSD is one of the thing that happens. PTSD is the one of the thing. It may happen in these kids, in these teenage peoples, that there may be, vigilance, there may be hyper vigilance, anxious, jumpy and distracted nightmare, emotional detachment, and avoidant behavior that lasts more than 6 weeks or more than 1 month. If these things happens, the nightmare, the flashback, the intrusive memory, emotional detachment, irritability, if happens more than 1 month, this is PTSD. This is not schizophrenia. Though in here you may feel like there may be auditory hallucination, but this is not schizophrenia. In schizophrenia, the Schneider-Faststein symptom should be thought. Trauma or focused cognitive behavior, trauma focused cognitive behavioral therapy, and antidepressant SSRI or SNRI should be chosen. Uh, like a 7-year-old girl is brought to the office, 6 months, 6 months of increased school refusal, 6 months of increased school refusal since starting first grade. The patient has been prolonging her morning routine argues when it is time to leave for school. The mother says she refused to get out of the car. This is not relevant. Our teachers reports that the patient gets frustrated early and has difficulty following direction, either he makes up words rather than trying to sound them out or angrily refuse to read at all. He is unable to read. He has some sort of problem that he is unable to recognize or he is unable to match the words. The patient participate in the dance class after school and play with other kids. So he has he can play with other kids, he can dance, he can everything is normal, but he is unable to read. So specific learning disorder. So there is the fear of so there is a specific learning disorder. This person may have a specific learning disorder, may have a language disorder and other problem. Suppose a 5-year-old girl brought to the outdoor by her parents to a problems at school. The patient's teachers report that she is very quiet in the class. When she does talk, she frequently uses the wrong verb tense and is occasionally teased by the peers. Her parents report that she was slow to speak as a toddler, but they were not overly concerned as they had assumed that she was quiet and shy. The girl has a friend with whom she plays after school. She is able to dress herself, tie her shoelace, draw a triangle, audiologic testing, labs, normal. So he has problem in learning. That means there is language problem. There is a word called selective mutism, but in selective mutism, patient not only talk in the school, but also he will unable to talk in his friends too. So it is not selective mutism, it is language disorder. Why in language disorder is a common developmental disability in the children, found 5 to 10% children. Language disorder is characterized by persistent difficulties in comprehension. That means he has some sort of receptive problem or production problem. Receptive or production of spoken and writing language. It may involve the rules of the grammars, like he has unable to remember the verb tense, so he has some sort of grammar, syntax, morphology problem. He has some sort of vocabulary problem, unable to remember the vocabulary, functional use of the language problem. Overall, it's a language disorder. Language disorder interferes with academic functioning and increased risk of specific learning disorder like reading and writing ability. Early intervention, including structural language therapy and stimulating language development at school and at home, is beneficial and improve outcome. Reading disorder manifests with difficulty in fluency, comprehension, and or accuracy. Common learning disorder is dyslexia, which involves a pattern of difficulty with word recognition, decoding, producing sound associated with the letter or words or spelling, affecting both reading and writing. Dyslexia is some sort of reading disorder. There may be difficulty in finding word recognition and decoding, and some sort of behavior problem associated with behavioral problem and reluctance to engage in learning due to negative self-concept. Manifestation may not be apparent in other non-academic social settings. Learning disorder is common in children with social advertise and chronic medical, neurological, and chromosomal problems like epilepsy, diabetes, and Fragile X syndrome. These disorders are commonly comorbid with ADHD, depression, disruptive behavior disorder. Standardized testing confirm the diagnosis, and that is all about the language disorder. Like, I am going to a 33-year-old man comes to the office with a poor sleep for past 2 months. The patient says that most night I woke up at 2 a.m. in the state of panic. My heart started racing like some sort of panic disorder. I can barely stay awake at work because he is unable to sleep at night. So has problem in he has problem in working. He has problem in working in the daytime as the sleep has not completed. She filed a divorce 3 months ago, and her husband substance abuse and violent behavior toward her. Physical examination, lab normal. Mental status examination. She appears tired and her mood is depressed and anxious. The patient jumps when a nearby door slams closed. At one point, she appears to stare into the space and does not respond to her name for a few moments. So started near about 2 to 3 months before. So it may be some sort of panicking problem, some sort of nightmare, some sort of hypervigilance. So it may be the PTSD. Duration more than 1 month. In PTSD, nightmare, flashback, and there is emotional detachment and sleep disturbance is seen. A 12-year-old girl is brought to the office by her mother due to worsening grades and repeated absence from school associated with frequent stomachache. She has never had such problem before starting middle school. 6 months ago, she used to walk to the elementary school, but the middle school is farther away now. I have to take her to school myself because she refuses to get on the bus. The patient is worried that her mother will have an accident and not able to pick her up from school and says, I won't know what happened to her. The patient denies problem with her appetite and energy problem. So the girl is in intense fix up, like he's thinking about her mom would have happened something, but he does not want to leave her mom. So it's a part of fear of separation. Fear of separation or separation anxiety disorder is an excessive concern that somebody bad will happen, and reluctance to leave her mother, and suggestive of separation anxiety disorder. It is more common in children under the age but can occur at any age. Separation anxiety is common in 9 to 18 months. The anxiety commonly recurs when children start school and transition in some way. Some sort of somatic symptom like stomachache, nightmare, difficulty in sleeping, and may lead to school avoidance as seen in this patient. In adults, separation anxiety may present with persistent disorder from childhood and or can develop suddenly, and it may cause significant functional impairment. A 32-year-old man, 32-year-old man comes to the ED with insomnia. He says that I feel restless at night and I cannot get any sleep. I have tried reading boring books and drinking herbal tea, but nothing seems to help. As he is a physician, so initially he previously worked in the emergency department, but switched to doing shifts at urgent care clinic a month ago. The patient says I was seeing a lot of gunshot wounds at the hospital, so he has trauma, post trauma. Compared to my old job, this one is much calmer, but I still feel anxious a lot of time. He feel anxious. He see the gunshot wounds, but now he feel anxious. He still thinks about patients he treated, what he could have done differently to save them. He can done differently to save them. But the patient says the world has gotten too dangerous. The world is rotten. So what different I can do? So as he's a physician, he already make try to give some consolation. He already tried to consolate her, and he haven't uptaken be cognitive behavioral therapy. So this time, this patient need drugs. Prescribed paroxetine. Paroxetine is a drug of choice. SSRI is the drug of choice. In OCD, in PTSD, uh, cognitive behavioral therapy. In PTSD, trauma focused cognitive behavioral therapy, but in OCD, there is cognitive behavioral therapy is the primary treatment. Then SSRI should be given. There is the patients. If the patient having anxiety, sleep disturbance, weight loss, tremors, sweating, increased heart rate, look for thyroid, look for hyperthyroid. So order and serum PTH, serum TSH. Uh, a 32-year-old, a 32-year-old man with no significant medical history comes to the office with concern about recurrent episode of sudden head pounding. That means palpitation, chest pain, palpitation, shortness of breath, chest pain, dizziness, shaking, tingling his extremity for several months. More than four or more than four symptoms is needed to diagnose. So he has pounding, trembling, shortness of breath, chest pain, dizziness, shaking, tingling in her extremity. The episodes last about 10 minutes and are associated with feelings of unreality and detachment from his body. The patient fears having episodes while at work or driving, or worries that he may have a heart condition or serious undiagnosed disease. He has seen other physicians who perform extensive medical workup, but nothing found. ECG done, other tests done, nothing found, but features of panic. So it is panic disorder. Give if acute problem, acute distress, give benzos. If first line treatment, SSRI. A 17-year-old girl comes to the office due to disturbing images she has seen over the past year. She says that I had I would be standing in the kitchen helping my mother chop vegetables. Terrible images of stabbing her in the back with a knife would pop in my head. The patient is overwhelmed, anxiety. She described counting down five. to one several times and to try to get rid of thoughts. So he starts counting to get rid of such bad thoughts. The patient has no medical history, mental status should tense and anxious. Effect she becomes tearful when discussing how she one would never want to hurt her mother. She reports no depressed mood, suicidal ideation, gives sertraline. This is OCD. That means there is recurrent intrusive anxiety provoking thoughts, urge or images. Recurrent intrusive anxiety provoking thoughts, urges or images. Now pheochromocytoma, neuroendocrine tumor in the adrenal medulla, 25% inherited VHL gene, red gene, NF1 gene, VFL gene, red gene, NF1 gene. 44-year-old woman comes to the office. 44-year-old woman worsening anxiety prior to starting her new job 3 months ago. The patient had not suffered from anxiety or any other psychiatric condition. She experienced the demands of her new job as overwhelming, disproportionate to support and resources she has available to work. Around the same time, she started a new job. Problem is newly diagnosed hypertension. Patient is anxious, tremulous, diaphoretic. So episodic headache, diaphoresis, tachycardia, palpitation, and anxiety symptom, and drug resistance hypertension. Suppose a patient having hypertension, but it is slightly improved with antihypertensive medication, but there is tachycardia, there is tachycardia. There is tachycardia, there is hypertension, there is diaphoresis, episodic headache, anxiety symptoms. In the setting of new onset drug resistance, hypertension, and hyperglycemia, think about a pheochromocytoma. In firearm injury, if somebody has firearm problem, that 16-year-old boy evolution of the depression, he is on depression. Patient's father is avid hunter. The most important thing he has to suggest to remove all firearm from the home, because the 16-year boy is depressive. He may has some sort of suicidal tendency. Mm, Separation anxiety disorder. 4-year-old boy is brought to the office for an office visit. He has no medical problems. Start preschool 3 weeks ago. The patient's mother is concerned about the adjustment to the school. He wants to stay home, like his baby sister frequently takes a long time to get dressed and become upset when he dropped off at school. On the first day of school, she was embarrassed when her son stomped his feet, yelled, "Take me home," and wrapped his arms around her legs, physically preventing her from leaving the school. This is normal. In normal. This is normal development. And the last is panic disorder, chest pain, shortness of breath, sweating, pounding, going to pass out. This type of word indicates that he has some sort of panic disorder. It's a long discussion of the second part of the psychiatry. Hope you enjoy.